All right. Welcome, everybody. Fiona, did you want to? I'll pass it off to Fiona Kabegenye, PCNT from Uganda, to start us off.
Thank you, Leah. Good evening, everybody. Good morning or good afternoon from whichever part of the world that you are. And we're extremely excited about you joining, and we hope that we can have community connection and collaboration as we enhance the future of pediatric care. This is the second of the Pediatric Aerodigestive lecture series that brings the speech and language experts to share the knowledge and discuss innovative treatment strategies for us today. And we hope that through their shared expertise and teamwork, we can create a stronger and more connected healthcare community. And again, the future sessions will be held online via Zoom in the next 2 weeks. And we'll be having presentations from other people. So the pulmonologists, the gastroenterologists, and pediatrics. That's me going ahead of myself for up next after this. Last week, we had the view from the pediatric otolaryngology, and we're really sorry about the timing. We hope no one is missed out for this time this year. And today, we have two amazing people who are going to speak to us. One is Meg. I'm not sure. I'm not going to speak your name. I'll let that be
Cafferkey.
clear. And then we have Catherine Nakawunde Lutaaya, who I will make introductions for, as she will go first. So it's my pleasure to introduce Catherine Nakawunde Lutaaya, who's an acute medical speech and language therapist at Ashford and St. Peter's Hospital in Surrey. I hope I've said that well, United Kingdom. She's a certified member of the Royal College of Speech and Language Therapists. She specializes in stroke, brain injury, dementia, and head and neck cancers. She successfully established a speech and language therapy clinic at Nakasero Hospital and provided both inpatient and outpatient services, which significantly improved the holistic care in the hospital. She also pioneered the multidisciplinary approach to speech and language therapy for head and neck cancers at Uganda Cancer Institute. This is where I actually met her more than 4 years ago. And here people would collaborate at tumor boards and other specialists to deliver the comprehensive patient-centered care as we see it today. In addition, Catherine spearheaded a 12-month collaboration between Southern African and East African speech and language therapists, leading quarterly webinars to foster knowledge exchange and enhance clinical practices across the region. Catherine, it's been a real pleasure for you to accept to be part of this lecture series, and we're really looking forward to your expertise, to your experiences, and to learn more from you both. Thank you.
Thank you. And I'm going to introduce my dear friend and colleague, Meg Cafferkey. Meg is a speech language pathologist here with me at UCSF in California in the US, in the Department of Head and Neck Surgery. She specializes in the evaluation and treatment of patients with pediatric feeding and swallowing disorders, paradoxical vocal fold motion, chronic cough, interdisciplinary assessment of resonance and velopharyngeal function, and voice disorders across the age spectrum. So she works both on the pediatric and the adult side. She joined our division in 2015 and is involved with both the pediatric ENT multidisciplinary clinics. We host a voice and swallow clinic together, as well as she's involved with the Aerodigestive Clinic and Trach Vent Clinic. She also is involved with the UCSF Voice and Swallow Center team here. Her areas of clinical and scholarly interest include working with families and treating their children with swallowing and feeding difficulties as they present in the aerodigestive world. And that will be the main focus of our talk today. The real goal of all of this is to optimize safe feeding progression. She also holds a certification in lactation consulting, so she plays an integral role in helping assess newborn feeding in our division as well. So thank you, Meg, for being here. And with that, I'll hand it off to you to kick off the lecture today.
Thank you, Leah. I'm going to share my screen first, and then All right, can you see my main page?
Yes, we're good.
Okay. All right, so thank you for having me. I'm so excited to be here. I'm going to speak with you about my perspective in our while working with pediatric patients with aerodigestive disorders. I don't have any at all. So my objectives today are to discuss common conditions and challenges with in pediatric aerodigestive disorders pertaining to dysphagia, discuss dysphagia assessment, the utility of clinical and instrumental approaches, and then we'll discuss feeding therapy and nutritional management in pediatric dysphagia and feeding disorders. So our American Speech and Hearing Association has a scope of practice statement that I really abide by in my everyday life. And it says that we as SLPs share responsibility with other professionals for creating a collaborative culture. Collaboration requires joint communication and shared decision-making among all members of the team, including the individual and family, to accomplish improved service delivery and functional outcomes for the individuals served. So my responsibilities as a medical speech pathologist are I have specialized training in pediatric voice and swallowing disorders. I have expert knowledge of laryngeal structures and functions, as well as mechanisms of voice and swallowing, including neurologic controls of these processes. I evaluate structure, function, and behavior of the upper airway. I provide behavioral therapy to improve voice and swallowing functions. I provide compensatory strategies when necessary, and I'm responsible for providing education and training to families and those patients. So the following are Kahneman syndromes and neuro-based conditions that we encounter in our clinic. These include trisomy 21, charge, 22q11, deletion, Pierre-Robin, craniofacial syndromes, neuro-based disorders, including cerebral palsy and Chiari malformation. These patients present with a unique and multiple issues impacting cardiopulmonary, airway, and GI systems. And when one or more of those symptoms are disruptive, swallowing can be impaired. And then that results in feeding issues or swallowing issues, including oral motor delays, pharyngeal motor dysfunction, resulting in aspiration and risk for pulmonary sequelae, or oral hypersensitivities, including food selectivity and refusals, and then ultimately poor nutrition. And if the child is not achieving appropriate nutrition and have limited appetite, this can result in cognitive slowness and fatigue, which then impacts their ability to feed successfully. So where do we start? Intervention begins with communication within the medical team. And so this is where these multidisciplinary clinics really can be really invaluable. So I want to know, is the patient stable from a cardiopulmonary or airway or GI standpoint? I need to have a clear understanding of their medical needs prior to even, prior to my assessment. And I want to know, can they consume anything orally yet? This is the beginning of our clinical evaluation. I'm looking at, can they even just manage their secretions? And, or I'm going to do a general oral motor assessment, looking at strength and range of motion and symmetry of all those oral structures, looking at their reflexes. Are they present? Are they supposed to be present based on the child's age? And then how are they feeding now? Are they getting full oral feeds? Are they getting some enteral feeding or full enteral feeds? And how are they managing that? And then are they growing and gaining weight? And if they're not ready for full oral feeds, I understand that the first year in an infant's life is the most critical period for feeding, and where food acts as a stimulus in the development of oral motor skills. So if the child misses out on those critical periods in development, the skill is more difficult to acquire. So how can we maintain their skills in line with motor learning principles while optimizing safety and preventing pulmonary sequelae? And how do we avoid oral aversion? So perhaps maybe we're offering to those who are not fully being fed yet, or maybe not safe for full oral feeds, maybe we're starting to offer them dips and tastes of either their mother's breast milk or their formula via like just a little pacifier, just to give them that exposure and give them that suck stimulation. Or maybe we're dipping a teaspoon in some pureed and letting them sort of lick the material off the teaspoon, or even on their own finger and letting them just bring their hand to their mouth to get that stimulation. Or in working with the medical team and weighing risks and benefits, are we able to give them small, like 10 cc's of bottle feeding just for practice, knowing that the risk may outweigh the benefit. And so this is the conversation that we have with the medical team, and often in the same room to make those decisions. And then at what point should we consider conducting an instrumental assessment? We have two types of instrumental assessment exams that we utilize to assess oral pharyngeal physiology and to determine what treatment measures need to be implemented to optimize safe oral feeding. So the first one is the video fluoroscopic evaluation of swallowing, otherwise known as BFSS, and then the flexible endoscopic evaluation of swallowing of fees. The VFSS is in radiology. It's basically a moving X-ray of the swallow from the very beginning, from the oral phase, all the way through pharyngeal and into the esophagus. And then the flexible endoscopic evaluation is we pass a nasoendoscope through the nose, and we sort of hover within the nasopharynx and a little bit below, and we can then see swallowing in real time. Both of these measures assess pharyngeal swallow physiology and can determine safety for oral feeding. They both assess the swallow with a variety of liquids, textured solids, and bolus size. They allow for judgments based on physiology of the swallow function. They both assess for airway protection, and they both assess for safety with swallow maneuvers or strategies. The flexible endoscopic evaluation of swallowing has many benefits. How do we determine which assessment is best for the patient? So when I'm thinking about if I'm going to do a FEES, if I want to see, I know that a FEES is going to give me direct visualization of the tongue base, the nasopharynx, and the larynx, and really assess for structural abnormalities. A lot of times in my day, I'm doing a FEES in conjunction with the otolaryngologist in my office, and they're looking for those structural abnormalities and what they need to intervene on, possibly surgically. And I'm looking at the function and how can I intervene functionally and therapeutically. I'm looking at secretion management, and this is a great test for secretion management and readiness for oral feeding. It is portable. It does not require any radiation exposure. We can assess strategies and give biofeedback with any time, without any limits to time. And then this is great for surgical patients looking at pre and post-op, or those patients that really sort of need serial examinations, and we don't really want to give them a lot of radiation like we would in the video fluoroscopic swallow study. And then this is the only instrumental assessment that we have that we can utilize for breastfed infants. The downside is that you can only assess before and after the swallow because of the nature of where the camera is. And during the swallow, the epiglottis flips over the airway, and the light from the camera reflects off of the epiglottis during the swallow. And so we can make some judgments, but we really can't see what's happening. And it doesn't assess for that oral phase of the swallow and the esophageal part of the swallow. And then some children just don't tolerate the scope. This is a video of a typical kid with a typical swallow. And so I'm just going to play it real quick. I might skip through a little bit just for time's sake. We're in the nasal cavity, entering into the nasopharynx. And then we're going to dip down. We're actually going to have them do a couple functional things as part of our assessment, but I'll maybe try to skip through that. Looking at some functional things that I'm going to pause here and just orient you really quickly. This is the posterior pharyngeal wall. This is the base of tongue. We're looking at a mirror image. So this is the right side and this is the left side. Right here is the inlet to the esophagus. Here's the epiglottis. Here's the vallecular space. And then lateral channels down into the piriform sinuses on both sides. Just below the epiglottis there, which you can't see right now, is the vocal cords, which you'll see in a minute. And then the airway. Typically, in a normal swallow, we would expect to see nothing, almost nothing. Sometimes we'll see a little bit of the bolus come to the back of the tongue here, or sometimes even spill into the piriform sinuses, and that it can be considered within normal limits. But we don't anticipate ever seeing anything left over or anything in the airway. Here they're swallowing some liquid, they're going to swallow. You see the epiglottis sort of come back up and the liquid is gone. And that is a beautiful swallow. So thinking back to which assessment is right for which patient and how FEES is really the best assessment for secretion management. We have patients who, when we start to see them, they're not necessarily ready for taking in any PO. And so we oftentimes will do a FEES just to look at secretion management and how are they swallowing? Are they able to clear those secretions? Are they able to get a good pharyngeal squeeze to sort of help make all that stuff go away? This is a patient population that we see a lot in our clinics. This patient has CHARGE, which stands for coloboma, heart malformation, cranial atresia, delayed growth, development, genital hypoplasia, ear abnormalities, and deafness. And what we know about this patient population is that they have lifelong feeding and swallowing difficulties, primarily due to cranial nerve dysfunction, and most require enteral feeds. However, swallowing function can improve over time. So it's really important that we follow these kids kind of closely in our clinics, and we also provide ongoing therapy for them as they're developing and growing and changing. Display here. So this is a little 6-month-old baby with CHARGE. And the mom and dad just want to know, can we start giving them tastes? And so we got in there with the scope and we just wanted to look at their secretions. You can see their epiglottis here. And this right here is our secretions, these white sort of foamy secretions sort of popping in and out of the airway and sort of spilling into the airway. And that baby's trying to swallow. You see that white out, but they just really are not strong enough yet. And they just really don't have the ability to clear those secretions. And so we're maybe not going to start any sort of significant feeding yet, but we're certainly going to intervene and provide some stimulation. So those under 12 months sort of babies, they're pretty easy to convince, or we don't have to do a lot of convincing to pass the scope on them. But our older kids, we really, to get a good study, we have to convince them that this is a good idea. And so we do a lot of work on the back end to prepare them. We have a FEES kit that you can see here with a baby doll and a little pretend scope that we made. There's also an NG tube in there for other purposes. And there's a bottle and actually some nasal spray that imitates our lidocaine spray that we sometimes use for patients if we decide that numbing their nose is a good idea to help them tolerate the scope. And then we also have like a coloring book that was actually created by Cincinnati Children's, and it's on their website. And it's a social story that we can give to the family ahead of time that's going to really prepare the patient, and they can read the story with their family and really prepare themselves for what's going to happen in the room when they get there. We're always going to talk about the purpose of the procedure ahead of time. We go through we discuss that we're going to make a movie. We prepare them for the nasal spray and what the scope is going to feel like. And then we even talk about what they're going to have to eat and drink. And then we let them explore the scope. And then we say that we're going to watch a movie afterwards because they're going to get to see their exam on camera after. This is an example of sort of a multidisciplinary swallowing clinic where we did a lot of the work on the back end to get this kid to participate in FEES. In the room is our child life specialist who has specialty care in preparing patients for, or specialty training in preparing patients for procedures. Myself, another speech pathologist, the otolaryngologist, there's an interpreter in the room, and the parent is holding the child. And so you can see the camera behind the child.
You have to hold your head, buddy.
They're drinking from their own cup.
Swallow it.
And then we're watching them swallow. And then we actually, after they swallow, we sort of dip into the airway, have them say E. So we're looking for any residual patterns to assess for complete airway clearance. So the modified or the video fluoroscopic evaluation of swallowing, are also known as a modified barium swallow study, also has lots of advantages. It assesses movement patterns of the bolus from the oral cavity all the way through the esophagus. It provides information on bolus transit time, coordination and timing of swallow event, and motility. And it can assess when and why the patient penetrates or aspirates. The downside is that there's exposure to radiation. The equipment is not portable. It does require us to mix a barium contrast with the food and liquid. And oftentimes for our picky eaters, that can be really hard. It also changes the consistency of the liquid or the food that we're trialing. And then because of the exposure to radiation, we're limited in the swallows observed. This is a young adolescent, and then this is an infant. These are normal, typical swallows that we expect to see. This is just to orient you really quickly. This is the oral cavity. You can see that this is the posterior pharyngeal wall along the spinal column down into the esophagus. In front is the trachea, the laryngeal vestibule, and the vocal folds. We would expect the swallow to be initiated just about the ramus of the mandible. And then really this patient being able to form a cohesive bolus as they're chewing, initiate the swallow, and then clear the bolus completely, and they did. And then this we would see, with an infant, we see very similar, except for this sort of suck swallow sequence, and this is a very coordinated swallow, complete airway protection. It's very beautiful. So I'm going to spend the rest of my time really just talking about a patient population that we see a lot, and this patient's story. So trisomy 21, these children tend to have increased incidence of airway anomalies such as laryngeal clefts, laryngomalacia, and tracheal ring, as well as lung anomalies, including hypoplastic lungs and decreased alveoli in lungs. There have been multiple recent retrospective reviews of children with trisomy 21 and dysphagia. We know that they have atypical development of oral motor function. 50% present with oral and pharyngeal dysphagia between the ages of 0 to 12 months and beyond, and it persists. They have high incidence of silent aspiration, and most often with thin liquids, and mostly just because of their oral motor delay and oral motor dysfunction. So this is a patient that we saw. He's an X34. He was born at 34 weeks. We saw him at 20 months in our clinic. That was our first time we assessed him. He has history of severe obstructive sleep apnea, dual dental atresia, post-repair, gastroesophageal reflux disease, seizure disorder, and severe hypotonia. He was seen previously at an outside hospital due to an admission for aspiration, and during that time, he had a inpatient video swallow exam, and he was placed on a thickened liquid diet, and we call this a level 2 or mildly thick liquid diet. And he was only able to be fed laying on his side in a sideline position. Because this really helps sort of like allow the patient to let the bolus sort of pool in their cheek and gives them a little bit more time to swallow versus working against gravity and a cradled position. And then the parents came in wanting to know if they can start puree tastes in an upright position. So we said, okay, let's do a swallow study on him. When I first met him, he had really severe hypotonia, and sitting upright, he couldn't even really hold his head up very well. And so I was really worried about even introducing purees to him. He was a full oral feeder, and parents were not interested in enteral feeding at this point. So this is his swallow study, and the first video is of the liquid that he was on. So this is his level 2 liquids, and so you'll see as he starts to get going, how the coordination of his swallow is different than the other swallow that we just viewed. And he'll start to sort of penetrate material into the airway, and then eventually starts really penetrating more and more until he's ultimately aspirating. And then so we actually thickened his liquids a little bit more to a level 3, closer to level 4 liquid. And he actually did a lot better. He has better control over the bolus. He's protecting his airway. And so we decided that this was probably a good idea. We're gonna give him an opportunity to continue to feed orally. He looked like he was better when we thickened his feeds, and then my job was to follow up with the family and make sure that they're thickening okay and feeding's going okay with him. So I recommended that he do sort of what we call like it was a level 3, but closer to level 4 on the spectrum of the IDSE framework, and I'll talk about that. The IDSE framework is the International Dysphagia Diet. It consists of a continuum of 8 levels, where drinks are measured from levels 0 to 4, or liquids, and foods are measured from a level of 3 to 7. And it just really provides an international framework or language to be able to provide common terminology so that we all understand what texture is recommended for a patient. And then so for this patient, I did a lot of check-ins, but there was a lot of issues with thickening for him. The first issue was he was on a really specialized diet, so he could only have his diet, because of his seizures, he could only have a certain amount of carbohydrates. He was on a ketogenic diet. And so with the thickeners are often starch-based or have lots of carbohydrates in them. And so I had to work really closely with the nutritionist to make sure that he wasn't getting too much thickener, but he also needed a lot of thickener to be able to stay safe in terms of his swallowing. And then he also was on some medications that they had to put in his feeds, and that also thinned down. his bottles. And so that was really challenging for us and really challenging for the family. So we decided to bring him back to Aerodigestive Clinic and get sort of everybody in the room, because at this point the family was frustrated, but also not quite on board for getting alternate means of nutrition, getting a G-tube. And so we needed to sort of get all of our heads together to discuss with the family and the team. And so we brought him back to Aerodigestive Clinic. And at that point, he came in actually sounding really congested. And he was coughing during his feeds, and parents were like, this is just so hard. And so in the room, when we decided to do this fees to really see what was going on with his current bottle that parents had brought in, we had everybody in the room. We had the pulmonologist, we had the GI doctor, we had the otolaryngologist, and myself. And so this is his fees. And you can sort of see you can see that the epiglottis sort of hopping up and down as he's sort of sucking and he goes through, and you'll see like as the airway sort of opens back up, you'll start to see just residuals, lining of residual throughout. It's really sort of like a messy swallow. This is definitely not what you would anticipate, or we saw in that example of a typical kid with a typical swallow. And so as this baby is sort of like going on, we start to see more and more glimpses of the airway. And then right there, you can sort of see just the white at the level of the vocal folds, and that he's just aspirating. Let's see if I can get there. You can just sort of see that lining of the white at the vocal folds there, and it's just escaping below. So we had a conversation with the family at that point, and we actually admitted this patient to the hospital. The parents agreed that maybe it was time for a G-tube, and we actually didn't think that he looked really good, in the sense that he looked pretty sick. And so we wanted to admit him right away and get him a G-tube. And so unfortunately, while he was in the hospital, he did end up with a respiratory illness and went into respiratory failure and ended up with a trach. And so he left the hospital not only with a G-tube, but also a trach. And so we followed him for the next year through the team. At that point, he was just too sick to really do oral feeding. We continued to do some stimulation activities to keep him sort of interested, but he at this point was not really managing his secretions. He was actually ventilated at one point. And so we were working more towards, as he was growing and getting stronger, we started to work towards weaning him off the vent and then decannulating him. And then we started to notice, like, while we were working towards decannulation, he was really managing his secretions a lot better. And he was starting to like sit independently and crawl. And so he's demonstrating a lot of developmental milestones or markers for improvement. And so we brought him back to clinic, and parents wanted to know, can we start feeding him again? And we were like, let's see. And so we didn't have to bring him down for a video swallow, and we didn't want to, because he hadn't really eaten for almost a year. So we brought him in for another fees. He's a little bit upset at first here. But what we're going to start to see is that he is swallowing. We're giving him little tastes of puree, and that's his swallow. And there's nothing left. There's little secretions that get on the camera there. But as we get to see again, he'll swallow again. his airway is really clear. Look at that. It's so beautiful. And so he's ready. He's ready for some tastes. And so we recommended that we start really getting him going more consistently with feeding therapy and getting him going with some taste to start building those developmental skills. So for my therapy goals, I typically my goals are always to support the development of the feeding skill. That's my first goal. And then focus on supporting nutrition and hydration. We're promoting growth. We promote the expansion of food, textures, and flavors. And then where needed, we will do those modifications. And, we always try to modify before we start thickening, because thickening is really just a pain in the sense of it is inconsistent. Not all families can afford it. It's not covered by insurance. You can use real food, but that's inconsistent. And so there's just so many other complications that come along with thickening. So we really try to optimize the feed by slowing down the flow of the bolus. Can we do more measured boluses? Can we change the mode in which they're eating and drinking to really optimize protecting their airway and safe swallowing? And then lastly, just some considerations for therapy. Swallow rehab for adults depends on memory for motor components of swallowing, whereas in infants and children, new skills need to be learned. And therapy goals need to be geared towards motor learning for feeding and swallowing skills during the mealtime itself versus oral motor exercises. And we won't make any progress in therapy if medical is not addressed first. And so working with the doctors and the medical team is so important. And the communication is probably the most important part of my job. And then therapy goals should always be created with the family and consideration of their cultural beliefs, their social influences, and their access. And that's it. Thank you.
Thank you, Meg. That was very insightful. I haven't seen any questions in the chat, so maybe I'll just let Kathy have a go with her presentation. For those of you who came in later, please feel free to include the questions in the chat. You can also tell us where you're coming from. Yeah, so we're excited to hear from you, Kathy, as well.
Thank you. Thank you, Fiona. Can you hear me?
Yes.
Okay, amazing. And I think I've already shared my screen. Are you able to see that?
Yes.
Okay, thank you so much, Meg. I really have learned a lot, and obviously there is so much that I would have never known. But I think what stood out for me was how you prepare these children for fees. That's something I haven't really had to experience hands-on with the children. In my own experience, I felt like it was maybe even impossible, but it sounds like a really good job and all the preparations that the kids go through. So yeah, that was really nice. So I have tried to go through my presentation as you presented to make sure I don't have a lot of overlaps, but also to save time. So I hope I don't really keep people around just saying the same very things. So I'll mainly just give an overview of what it is like, especially in Uganda. It may be a little similar around East Africa, so hopefully it'll give a slightly bigger picture. And
Kathy, would you like to put your slides in
a slide?
Yes, please.
Okay, so that is the slideshow. Okay, I'll try to first stop sharing and then do a slideshow of that. Sorry, this may not really look up. No. Does anyone know what I can do
You could put it back again.
Okay, so I've done on the slideshow. I have
You have to first share.
Yeah. Okay. Let me undo the sharing. Yep. I've done the share. And then
Okay, so in the bottom left or right.
at the bottom, yep. Slide sort.
Continue. Keep
Yeah, I'm at the
going.
bottom.
Yes, the next one.
Slide share. Is that better? I can see the slideshow coming up.
You can also go the top left corner. It says from current slide. That should do it.
Okay.
On the top left corner, there's text.
Come on. On top left corner. I'm trying to get off because it showed as though it was giving me a slideshow, but now try to get off gosh. Yeah. Okay. Can I end sure? Yeah. Okay. So someone was telling me from the top left.
Yeah. The share had kicked off again, though.
Okay, so I have to share again.
Yeah, and if it doesn't work, I think we can see if you just.
Okay, so if I go to my Windows and share my presentation, and then top left, I can see from beginning.
Yeah, beginning or current. Yes, that would work typically.
Yes.
Okay. Can you see it? Is that okay?
Yeah, it's still showing your sidebar, but I think if that's, I think it'll be
if it's
fine.
not working.
We can see it. Yeah.
Oh dear. Okay.
Yeah, not to worry.
Okay, so Meg shared a bit about all of the common signs and symptoms and complications. So I have a few bits I collected from the Ugandan speech and language therapists. So I had about 51 of them saying they were quite interested in working with dysphagia in pediatrics, and they're currently doing it in more than one setting. So the reason we emphasize numbers in Uganda is because the number of SLTs is just growing, and it's still concentrated around the central part of the country. So yeah, we're kind of like keeping tabs on the numbers. So a lot of them say they're actively managing pediatric dysphagia, and a few of them say they would love to, but they either haven't got the opportunity or that perfect place where maybe they're in an MDT team where they have maybe ENTs or surgeons referring to them. And then 6 of them were just saying they only have worked with adults because that's the only referrals they've received. So again, 14 of them filled out a very good kind of like questionnaire, which showed how they're currently managing. But people in Uganda, I mean, SLTs in Uganda definitely work in more than one place. It'll be a hospital or clinic or school. So we'll manage dysphagia in all these areas. So you can imagine sometimes it won't always be an MDT team altogether, even if the child has been seen somewhere else by other professionals or other experts. So it comes with a bit of having so much flexibility and always thinking out of the box, or maybe taking a lot of the time trying to understand the child as a whole. So again, most of the conditions, Meg kind of like gave us an overview about the more complex or technical conditions that are SLTs manage in high environment. In Uganda, since it's usually a lot of community and school or even at home, because a lot of the therapists are contacted privately, so they do a lot of with cerebral palsy, Down syndrome, and a few other neurological conditions. So a lot of the children may be missed out with all the other functional and structural anomalies. So they may either be missed out or they may never see an SLT. But I think most recently, a lot of the SLTs have come up to say they are working in more medical and acute settings, which is a bit promising right now. So you'll also find that when it comes to history, it may be that the carers are the ones giving the history, the family, and sometimes may not be comprehensive for reasons we know that not all the information will be handed over to family. So it's sort of that kind of situation where an SLT has to go over and beyond to make sure they understand the patient. So again, Meg talked about these bits, our roles in early identification. It may be missed in certain settings, but I also have seen lately a lot of ENTs in Uganda are reaching out more and more each day. So we're really appreciative. And SLT's assessments are mainly clinical saloon evaluations. A few of them, which has been surprising from the questionnaire, have definitely said they've gotten access to fees and maybe the video fluoroscopies, and I do not know the frequency or how this is sufficient, for example, for the patients that need monitoring. But I feel like things are just emerging. So I think it's getting a bit more hopeful in terms of pediatric dysphagia and SLT supporting or working as part of the MDT team. So, and then I think I'll skip that. About family in Uganda,
Sorry,
I think...
Kathy, I'm sorry to interrupt. I think we can only see your title screen. I
Right.
don't know if you're flipping through slides.
Okay.
But if it might be, yeah, I just want to make sure that you're,
Yeah,
we can
thank you.
see all your good info.
All right, I'm gonna have to end that again. So sorry.
Kathy, if you want to email me your slides, I could also try
and share it. Okay.
Yeah.
That should be more helpful because trying to miss out. Okay, that'll be over to you very soon. Okay, so I've sent you the slides. Try and have a look. Have you received them yet, Fiona?
Not yet, sure.
Okay.
Kathy, try clicking. I think we can see your different slides now.
Okay.
If you
So
advance, just try advancing.
can you see those?
We see collaboration with the MDT.
Okay. Yeah. Can I work with that as Fiona gets her
Yes.
slides in? Okay.
Please, thank
All right. Yeah. So I wanted to chat about family involvement. So when it comes to SLTs, for example, in Uganda or around, you find that the families are the ones that may reach out. So maybe these conditions may not be as either critical or acute or complex in that sense, but it will mostly be the family that may reach out, except for the clinics and hospital settings. So the family may be the main person to, one, give the history, but also to support if it comes to care. So everything the SLT can train and hand over to the parent, they usually work hand in hand. It doesn't always work out, as some parents may be busy, others may really feel that the parent has to, some of them may feel like the SLT has to take on all the whether it's therapy or all the care. So it can get a bit challenging, and it may call sometimes for SLT to do a lot of education. And talking about interventions, so in Uganda and around, obviously the SLTs do a lot of feeding therapy, and a lot of them are similar to what Meg shared, but I wanted to chat about some of the few changes, some of the variations, for example, when it comes to nutritional management. So it may be quite rare to have a nutritionist, to access one, and obviously I got a bit of a shock when I came over to the UK, where they're actually even more where I work. I think the ratio is almost 1 to 1 SLT to about 5 nutritionists. So in Uganda, it may be quite difficult to find one. And if you do, they may be general or they may not be very specific to pediatrics. So SLTs around Uganda would tend to have a bit of more extra knowledge. And obviously this would be a bit outrageous in other countries, but in Uganda, you may find that the SLT may be the closest or the only kind of contact to find nutrition advice and education. So SLTs will take this upon themselves as well. And but things like modifications of either feeding materials, I think in a setting such as Uganda, that has also improved really. Parents are always very eager to get these resources. So the SLTs tend to do a lot of the fending and going out scouting for these resources. And they are usually, SLTs are usually they usually have to be more resourceful or very resourceful, as there are not so many very settings to find resources. So yes, and even it comes to whether it's behavior strategies, training these skills to the children, you find that SLT has to either be the one who is constantly doing it if the parents do not really come to that understanding that is that they can actually, I think it's more like being empowered and feeling like they're also in position to support and train this child. The SLT may take on the role to actually do more therapy. Otherwise, when it comes to parents who may be more open to learning and a bit more encouraged, you find that SLTs are even in position to just do monthly reviews to support these children. And even when it comes to private therapy, which is more popular in Uganda, again, if a child can only afford one session a month, you find that they're having that frequency of reviews, and that's how frequently they'll be seeing the SLTs. So working indirectly with parents is heavily relied on in Uganda, and we've seen it being effective in a lot of settings. So next slide is, so yeah, we do have, I think it's a really growing field, and definitely we may have a few challenges, but again, I tried so much to hear from the SLTs, and as much as the challenges have been there, it looks like a lot of advancements have actually come around. But usually when it comes to the complex symptoms, in my 3 years, I think when I was in Uganda, for example, I only got to a child who had, it was trisomy 21. I only got a chance on this once, and I found this child at home. This child had been not exactly discharged, but this child had more like a full hospital setting at home. They definitely had a small jaw, big tongue. They had an NG in when I reached, and this child was at home. So it wasn't really a referral from another medical professional. It was the mother who did a bit of searching and found a speech therapist. And on arrival there, I really had to take more time to actually kind of gather all the history and to kind of understand what input they've had and what medical decisions have been made around there. And luckily, there was a bigger team. There was physio. I think there was also a doctor, a general doctor who kept coming around. So eventually I got some support. But now I feel like more SLTs are saying they're working in hospital settings. So again, I think it's really, really a good sign. But with this child, again, I think it was that lack of joint decision making. And as an SLT, if I did my sessions or if I did my evaluations, it was difficult for me to decide, because at some point when I had to tell the mom, it looks like this sort of, maybe we can say severe dysphagia. This child could not go past the oral phase. This child, we could not visualize a lot of the oral structures. It was really to that extent where maybe having a joint medical discussion and maybe support of the mother would enable her to make other decisions, including maybe long-term feeding. So there's these complex cases where the setting may not really favor decision-making or outcomes in a sense where everything has been explored at least. So yeah, and then diagnostic tools. A few of the SLTs responded and say they've accessed MBSS. So that sounds like promising. And also some of these SLTs, a lot of, actually, out of the 13 of them say they've mainly worked with children who have NG tubes, but also these are the same SLTs who may not really have frequent or enough access to maybe more advanced assessments. So if there is no fees to see the risk or the extent of dysphagia, you may find that maybe an NG tube is not really the best recommendation, or maybe some of these children may actually have oral intake. But again, those are some of the things we have to work around with. So NG tubes may be more common. And again, I think the fact that now more of SLTs is starting to work in hospitals, that may actually give some hope that with more ENTs able to support these advanced assessments, it may be that more children will actually start oral intake more frequently, and maybe less NG tubes will be there if they're not needed. So I think Meg shared these, some of the strategies: ongoing education, MDT approaches, and then advocacy. I think I wanted to go down to something, I think nutritional management, Meg shared, but also I've already given my perspective or what I've seen, what happens in Uganda. Yes, when it comes to nutritional interventions, when I came to the UK after practicing in Uganda, obviously I found that, there is the IDSI levels, which are more standardized and they're more consistent. But in Uganda, you may find less thickener being used. But again, obviously, like Meg said, as much as there may be more advanced techniques and approaches, sometimes they have disadvantages, and that in Uganda, where you may not find out of thickener, we're able to improvise more and modify food more before we actually start changing it up with maybe thickening and all of that. So you find that a lot of Ugandans rely on, for example, or even East Africa, they'll rely on porridge textures and assess with these, other than saying, oh, fine, let's get thickener. Even with food, they will match that readily available food and assess the child with that. So I feel like we have that opportunity to explore more natural means and more natural food before we kind of jump over to sort of the industrialized or more complicated sorts of treatment approaches and adjustments. So yeah, I feel like in a way it's a good thing, but also it will be good for us to have more opportunities to access and exercise more advancements. I think the rest Meg has shared. Obviously, if for
Catherine,
example,
I think I'm behind you. I'm not sure which slide you're on.
slide 16.
Okay, sorry.
Yeah.
Thanks.
Slide 16.
Okay.
Okay. Thanks for that. Okay. Yeah. Talking about hydration again, I feel like a lot of children who came around to the clinic, the young children who may have dysphagia in that case, they were taken care of by either a second or a relative who's not their parent, but it's in such a setting that sometimes they're very, very small things, or they're culture things where the main parents of the child may actually feel overwhelmed and kind of like give up the care to someone else, which can be quite hard. And sometimes you find yourself kind of doing more than you should do, or kind of getting off track, even trying to support, for example, a grandmother who may come in with a child. But at least I think there is a lot of opportunity when someone brings a child to the clinic, then you know this person has really, for example, this person has really cares about the child. And a lot of them came from very far. For example, when I was at the referral hospital in the clinic, and I remember one time this child with CP who had a really, she had a dysphagia, she had an NG tube initially when she came around, but the grandmother had really done a lot of good oral care, which was quite impressive. Good oral care, and obviously by then the strategy we used was fine. If we had to have fluids, let's have water, and for the other fluids, they may have to be a bit more thickened. I mean, more. What can I say? Thicker fluids, not thickened with thickener, thicker fluids. So I realized that even in such a setting, you can always work out. So it takes a lot of flexibility, but I really appreciate the differences. And I think yeah, with nutrition, it gets on. Sometimes you actually have to get your own education. Other times you can actually remotely. Other times you may actually have to remotely consult a nutritionist. So I remember for my own learning, I found a few colleagues who I used to contact and ask a few questions. And especially if I was if I'd been put in a position to make some decision nutrition-wise, and I really didn't have any support, I would have to go and evaluate my decisions and even maybe update my knowledge about the decisions I gave, or the recommendations I gave to the parents. Whereas when I came to the UK, all of that is away now. There is always someone, and there'll be someone for you to consult as regards that. So yeah, about MDT approach, I think Meg shared that. And then case studies, I think Meg really had very good case studies. I'll just skip on to slide 21. Yeah, so in our settings where we may find that maybe we're still developing, I feel like something such as joint assessments will kind of like empower. One of my most empowering assessments was when I was maybe with an ENT, because by then, without having any skills in instrumental assessments, they were able to at least give me a picture of the structural overview, to give me a picture of some of the functional overviews, even if the fees maybe was not there continuously to monitor progress. So I feel like that empowered me more, and some of these professionals really understand the role of the SLT, and they will really also help you learn more. They will even direct you. They will actually share with you what they've seen elsewhere, and with that you can improve your learning. So I feel like joint assessments in an environment where this MDT collaboration is still merging, there would be really one way to quicken up the process of having joint and holistic patient care. Even shared treatment plans. I feel like if the professionals knew that with every child that I've seen, at least I have to call out an SLT, because we know that most of the hospitals may not really have a role of an SLT. But if we have one who can come in directly, and with every child, at least they are consulted, or they maybe do an assessment or an overview and maybe support in one or another, that may actually really improve holistic care, even if there is no particular significant role given to an SLT. And always continuing education. So I'm really, really grateful about this platform and this program, Many Kids, because I feel like it's also a sign that there is more education going on. Obviously, in Uganda, as much as in Uganda, there are things that I feel like we are more of like a canvas where all the technology and advancements may actually are welcomed. For example, in Uganda, most of the SLTs are focused in the central region. However, we have people who have actually been able to hop onto a Zoom because they're outside of Kampala, because they're in the other regions, and they may be able to access these services. I've seen, I think, on telehealth, I've seen on Royal College, there is a whole competency about people who would like to practice in dysphagia, specifically telehealth dysphagia, which is something I thought would never be impossible, because that you may think that may be more in communication. But imagine if a child cannot access any professional services but can contact someone over telehealth. So I feel like some of these advancements may really, really be good for us. Advanced diagnostic tools, there is more merging, but we are still even trying to get more frequent of the ones that have been around for long, the fees. So all the ENTs who are here, please, when the SLTs reach out to you to ask for your opinions or to suggest these instrumental assessments, please support them as much as you can. And yeah, I think that's everything from me. If anything else, I think was already shared by Meg. And yeah, I don't know if there is any questions. Otherwise, that's everything.
Thank you, Catherine. I'm so sorry I botched your presentation.
No,
I wish
it's
I'd left it out.
that was helpful. I was panicking because I was like, where is it going? Yeah.
I'm trying to look if there are questions in the chat.
Yeah, for anyone with questions, please do feel free to chime in the chat. We have both Meg and Kathy still on. And for anyone just joining, I think there was a note that went out. The time is going to be consistently at 7 p.m. East African time, and we'll be sending out messages. We'll also be recording all of these, so if there's anyone who missed some of the material, it'll be available via recording.
Sorry, I had a few questions from myself. So I'm just curious how, as a SLT, you determine the silent aspiration. Would it be on the fees, or would you actually do some other like tests, bronchial lavage, and you do the lipid-laden macrophages? How further would you actually find out if the patient is silently aspirating? And then my second question is about, so in our setting, we tend to get lots of children who have Altimeter chronic nasogastric tube for feeds. So they have it more than 2 weeks, more than 2 months, and they just kind of come to the clinics every 2 weeks to have it changed. I am wondering if you have anything that you give as SLTs to manage reflux in that case, since the NG tube is within the space. And then what else? I had quite a number of questions. And then also curious to find out about if you deal with any children that have drooling issues, so posterior droolings, do you have any techniques for that before we go into surgical procedures?
Catherine, do you want me to respond?
I may not have much, but a few bits that I hadn't really sorted out. That I had some tips for example, maybe other teams if they want to look out for some of these children. I think I could have dropped them off as I was trying to balance out my presentation against Meg's. But I think as ENTs, you may be the first point of contact for these children, and you may come across certain symptoms. These children, for example, may be having fevers that are not really explained, that they're always having these fevers. That may be a sign that maybe there's been some ongoing aspiration happening. It may be already chest infections that are recurring, that every time this child is coming to you, there are reports of that, or they may have a long history of antibiotics on their maybe treatment charts. Some of these children will just decline food. They will just decline food because maybe it's not a really pleasant experience. And obviously, if they have history such as reflux, such as that, the aspiration may be happening on that. It could really vary. And from an SLT perspective, obviously, it may have to be instrumental. So I'll let Meg chat about that. It may have to be instrumental in that regard, so that they can actually visualize. But I think even from the fees, if an ENT is doing a fees, they may be able to maybe identify some of it, but an SLT will have a bigger understanding. For drilling, I'll still leave it up to Meg to give what strategy she's giving. And for reflux, it's always been the ENTs, and a few strategies such as maintaining positioning after eating, avoiding the foods that may trigger it more, but SLT will not medically, or pharmacologically stop the reflux. Meg, please share what you think.
I agree with all of those things that you said, Kathy. Those are exactly what I would have said too. Like beyond our, those clinical signs in terms of the silent aspiration, beyond those clinical signs, the real way for us to confirm that that's happening is through our instrumentals. And you can confirm either through the video swallow exam or the fees. And actually fees has, you can see aspiration greater with fees than you can with as more sensitivity with fees than the video swallow. And there's some data actually in the literature that supports that. And then in terms of the NG tube and reflux, it's really tricky. That's a really tricky one. I mean, for kids who are just getting their NG tubes changed every 2 weeks and really experiencing lots of reflux and and it doesn't really help that they probably have lots of low tone and so there's just other issues going on medically with them, and then now we're stenting open sort of their upper esophageal sphincters and their lower. I mean, sometimes I'll, chat with the GI doctors about just like, sometimes you can use like just by thickening the food a little bit. If they're taking in anything orally, thickening their feeds, like their oral feeding a little bit just to kind of weigh down their belly before they get anything. Or, there is some practice, I think, in the literature in talking to the GI doctors about thickening the feeds a little bit to weigh down whatever's going in the nasogastric tube. I know that they use like there's certain formulas, and then I don't really know that much about like using real food for that, but it's a possibility. Drooling is probably one of my my least favorite things to intervene on because it's just so tricky. There's just so many reasons why children drool. Depending on their cognitive status, some kids, it's more like when I intervene, it's usually more about increasing awareness. And so we'll do things like have the child wear like little sweatbands or put like just something around their wrist so that they can wipe their drool. So it doesn't make it look like so they're not wearing bibs and things like that to make them look a little bit more age appropriate, but they look very sporty and cool, but they can then their parents can then cue them instead of saying like, constantly saying to them, wipe your drool or wipe your drips. Like they'll give them a little cue on the chin or something, some sort of cue, and then it cues the patient to wipe their drool away, or it cues them to swallow. But it is sort of like, it becomes sort of like a behavioral therapy in some ways to sort of just create that awareness with the patient. And so for some patients that it can be really successful, and we can intervene and have success before needing to go into any sort of medical intervention. But that being said, we do rely on the otolaryngologist to also intervene in some cases or a lot of cases because it's so tricky.
Yes, sorry, just adding something small. So, yeah, I wanted to ask Fiona. Fiona, when it comes to the chronic NG tubes, are these NG tubes that you've been involved with in terms of like decision making, or because, for example, in Uganda, it's common for children to have that because they cannot access a speech therapist, or no one has given them any other advice, and maybe the children is coughing, or they're losing weight, or they're not just eating. So, maybe also another sign that a speech therapist may be involved to support going forward, because some of these children may actually end up losing these NG tubes if they're supported, whether with exercises to improve your swallow, to introduce or intake. So yeah, I don't know how the situation is and where you're at. It must be very difficult. I'm not sure what access you have to support with speech therapists. What's your experience like?
Oh, so unfortunately for my setting, fortunately for my setting, I'm speaking from a privileged point because we're right in the middle of the training institution. So when I need a speech and language therapist in the government setting, I'll call the head of department, and she will have me sorted. In private, we do have some people who will actually give us speech and language therapy services. And I have like 5 different people on my phone that I'll actually send a patient to. That being said, the patients that I see, so this one particular patient who had a chronic NG tube had come with it from the ICU, had a trach and the NG tube as well. So they came to me because they needed the trach to be decannulated and they had failed. And then I noticed that they had an NG tube. And so I actually sent them to an SLT who helped them with the swallow before we actually proceeded to take out the tracheostomy. But also in our setting, I'll just speak for a few people. Most of the times, the G tubes, to get a G tube done takes a bit of a while. And also, if they don't get access to the pediatric surgeons or the people who put the G tubes, we still do the open ones for most cases, but there are private facilities that can actually do the G tubes endoscopically. So I think that's one of the reasons why they take long with the NG tube feeding. And then sometimes they just don't want to take long. They just don't want to make the decision to actually have the PEG, the G tube. So they prefer to actually have the NG. But we do have access, at least centrally, to speech and language therapy services. It's just that not very many people actually reach out to them. You do have a question in the chat from one of the SLTs. Maybe I'll let Leah read that out loud.
Hi, sure. And I want to be respectful of time here. We'll try to wrap up in the next couple minutes. But Calvin Kisembo asked about a child. First gave his thanks for the wonderful presentations. And the first one regarding trisomy 21. He's an 8-year-old who 1 year back presented with language and speech difficulties. The continuing therapy for the last 1 year has improved his comprehension skill. However, speech is still characterized by 5 to 10 simple words and more pharyngeal-like sounds. Knowing that they present with oral structural anomalies, my question is, are there any surgical interventions to align the oral structures that would improve speech? I gave a brief response from the ENT perspective, since we're typically the surgeons who get asked about this, and it's a pretty unsatisfying answer, which I would say is really no. We work closely in our practice. Me and Meg will get a lot of referrals for ankylosing or tongue tie. I would say that's the most common sort of oral anatomic anomaly that people are concerned about, at least in our region. And the evidence is fairly sparse even for that to be beneficial, at least with the English language. I think there are some variations over different types of language, like Spanish. there may be some more limitations with not having a tongue that moves quite as well, but at least in our practice, we really evaluate these kids with, Meg plays a big role in that, and they're often referred for speech therapy every now and then. And ironically, today I'm actually doing a frenuloplasty or a tongue tie release on a bigger kid who has gone through a lot of therapy, and they've identified that specific articulation noises are still problematic for him. He also has severe issues where his tongue is just not moving great, so he'll end up pocketing food a little bit. So we're doing surgery for him, but it's very, very rare that we'll do that in our practice. And then, yeah, I defer to Meg and Catherine on other advice on that.
I agree. There's very little that we can do from an there's a very little we can do from an oral motor standpoint in the sense of like speech. And so like if there's any sort of anomalies, it's probably not the oral motor anomalies are likely not impacting their ability. It might impact their ability to be clear in some ways if they have like some, like with Down syndrome population, they have larger tongues. And so it may impact their articulation and clarity in some ways, but not their ability to actually say words and have that language.
I will amend my statement for things like velopharyngeal insufficiency, which is a whole other topic. And you can see, I think we don't see it much in the aerodigestive realm, but kids, especially with cleft, and I think Calvin, you might be working with the cleft team. You will see kids with velopharyngeal insufficiency, and there are a number of procedures that can, in some cases, address that. But yeah, that's a bigger topic, perhaps for another time.
Yeah, I don't really have much to add besides to say saying that maybe going back to goal setting for your speech and language may be helpful because sometimes some of this pressure may come from parents and even from yourself as a therapist. So yeah, kind of like going back to give that education and to reset your goals until you're at the point where you all agree and work towards goals that you may be able to achieve. And of course, read as much literature as you can access within the time you have with the 8-year-olds. So yeah, there may not be anything else that I can think of.
Well, great. Thank you so much again, Meg and Catherine, for your really wonderful insight and your expertise on this topic. As you all know, this is part of a larger series, as Fiona had mentioned at the beginning. In 2 weeks, we'll be hearing from a pulmonologist on their perspectives on aerodigestive management and some of the procedures and diagnostic and management options that they have for a lot of our shared patients. So thank you all for your time and participation. As I mentioned, this will be recorded if you missed anything, and feel free to reach out to us via Mending Kids and Dual CR coordinator if there are any further questions. And yeah, have a good evening, morning, afternoon, wherever you may be.